It's not just you as an individual that could potentially be affected, but even those around you, our community. That's how we were able to get rid of so many of these diseases that were killing people. The idea behind herd immunity. So if somebody don't fully complete their vaccination series, it's not just, you as an individual or, the mom or somebody making that decision, but it's also affecting the community. And so one decision can have a ripple effect for the entire community that you live in, if we don't provide the herd immunity, and also protect yourself. So I think that it's important to complete the entire vaccination series, no matter which one you start, to protect you as an individual, your family, your friends, and the community, so that these diseases that were killing people will not come back and flare up again in our communities.
A lot of people are getting sick and dying from this disease, such as my grandparents, so I think the best thing I could do was to get vaccinated. I think I chose to get vaccinated because I want to stay safe myself.
COVID has changed my life tremendously because before COVID, I was out a lot. I was hanging with my friends. I would do stuff that I love to do. I wanted to get vaccinated because I wanted to make sure people that were around me were protected.
It gives me that comfort knowing that I have something protecting me from a virus that's possibly really dangerous. The vaccine allows me to be able to do what I like and want to do normally without having to worry about the virus.
I decided to get vaccinated because if I could do anything to help get back to a normal life or get back to not wearing masks, and to get to see my family again, I'll do it.
The reason why I got vaccinated was to protect my loved ones. Getting vaccinated will allow me to do the things that I want to do, like playing basketball.
It's up to you, Missouri. Get vaccinated.
It's up to you, Missouri.
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 It's not just you as an individual that could potentially be affected, but even those around you, our community. That's how we were able to get rid of so many of these diseases that were killing people. The idea behind herd immunity. So if somebody don't fully complete their vaccination series, it's not just, you as an individual or, the mom or somebody making that decision, but it's also affecting the community. And so one decision can have a ripple effect for the entire community that you live in, if we don't provide the herd immunity, and also protect yourself. So I think that it's important to complete the entire vaccination series, no matter which one you start, to protect you as an individual, your family, your friends, and the community, so that these diseases that were killing people will not come back and flare up again in our communities.
Good morning. I'm Nicole Coate, the Executive Director of the Missouri Immunization Coalition. I'd like to welcome you to the Missouri Immunization Conference 2022 virtual conference. I think we can all agree that there's no better time to talk about immunizations than now. So I sincerely thank you for joining us. The Missouri Immunization Coalition is a statewide nonprofit organization that strives to keep all Missourians healthy by reducing the spread of vaccine-preventable diseases throughout the state. We do this by providing immunization education, advocacy, and promotion in partnership with our healthcare providers, local and state health departments, Missouri families, and through community outreach and events such as this conference. Over the next 4 days, we will be hosting a series of virtual lunch and learn sessions intended to educate all Missourians, healthcare providers, and related professionals on a wide range of topics related to vaccinations and health within the goal of increasing immunization rates throughout the state. But before we get started, I'd like to cover a few housekeeping items. To honor the observation of Juneteenth today, the Missouri Immunization Coalition will be offering today's presentations on demand. Registration for the conference includes access to the on-demand sessions. Information on how to access the on-demand sessions will be sent to all registrants following the live conference. We're using a platform called EventsAir to bring this conference to you today. There are some things to know and some things we would like you to take advantage of. By clicking on Meeting Hub, you can see a list of the people in attendance. This is where you can find your colleagues and set up conversations with them, just as you would do at an in-person event. When a session is completed, please return to your timeline. From there, you can visit the exhibit hall and join the next session. We strongly encourage you to visit our exhibitors. You may speak with them using the chat or video, or check out the resources they have available within their booths. If you like taking notes during the presentations, take advantage of the notes field. When the conference is over, you can email your notes to yourself, and they will be broken apart by session. Please use the live question and answer or the discussion forum to submit questions using a chat feature, and we will ask questions on your behalf at the end of each presentation. If you would like to take advantage of the closed captioning, please press the CC button under the video window. Live support for this event is just a click away throughout the entire week. You may also email cehp@missouri.edu or call 573-882-4105 for assistance. To all healthcare providers that are here, the University of Missouri-Columbia is providing continuing education credits for physicians, nurses, licensed professional counselors, psychologists, social workers, and pharmacists. So without further ado, I'd like to introduce our first speaker. Dr. Padhye is a pediatric infectious diseases provider and assistant professor of child health at the University of Missouri in Columbia since 2017. She completed medical school in India, and after pediatric training in the United Kingdom, a residency at the University of Illinois in Peoria, where she completed a fellowship in pediatric infectious diseases at Washington University in St. Louis. She sees both inpatient and outpatient settings at the University of Missouri Healthcare. Her clinical interests include pediatric vaccinations, antimicrobial stewardship, COVID-19 in children, and bone and joint infections in children, and is passionate about teaching pediatric trainings. Welcome, Dr. Padhye.
My name is Dr. Amruta Padhye. I'm a pediatric infectious disease doctor at University of Missouri. Thank you for being here on this virtual conference with the Missouri Immunization Conference. I am going to talk about the effects of COVID-19 vaccine hesitancy on routine vaccinations. I do not have any conflicts. I do have a disclosure that I'm a site principal investigator for one of the Moderna childhood vaccines. However, I do not plan to discuss any of the specific vaccines for COVID-19 in this talk. My learning objectives today begin with reviewing COVID-19 vaccination rates and the factors that have undermined the efforts during this pandemic. Then I would like to shift gears and talk about the effect of the pandemic on pediatric immunization rates in the US, followed by the key part of this talk, but again, that is also kind of intertwined with everything else that we will be talking, which is the effects of COVID-19 vaccine hesitancy on routine vaccinations. And I hope at the end of this talk, you may be able to apply lessons learned here to devise any strategies to increase your vaccination rates in your clinics, in your student population, etc. My outline is going to begin with a definition of vaccine hesitancy, and then thinking about the vaccine hesitancy continuum and talking about the psychological antecedents of vaccinations, followed by uptake of COVID-19 and determinants of COVID-19 vaccine hesitancy. Then we'll talk about routine vaccination rates in times of the pandemic, followed by the impact of both the pandemic and related vaccine hesitancy on routine vaccinations, and close with strategies to increase uptake. In my mind, I conceptualize this talk as being an interplay of the effect of COVID-19 on childhood vaccinations, decreasing the rates, and vaccine hesitancy that kind of feeds into this and also is fed into by vaccine hesitancy to routine vaccinations. This is how I conceptualize my outline of the interplay of the pandemic, vaccine hesitancy to routine vaccines, and COVID-19 related vaccine hesitancy, and its overall impact on decreasing routine childhood rates of routine childhood vaccination. We know vaccination saves lives. Historically, rates of fatal diseases have dramatically decreased since the 20th century to a staggering, impressive rate of 92 to 100%. Listed in this table are a number of up to 9 vaccine preventable infections, and included there also is congenital rubella syndrome. And kind of a projected 20th century annual morbidity, and comparing that to actual reported cases in 2016. It also emphasizes the role of herd immunity. As such, in 2015 to 2020, so just before or kind of around the time the pandemic started, we had seen the outbreak of measles in 2019. And this was scary because as a vaccine preventable disease, we saw an increase in number of cases from 188 in 2015, with some fluctuations in the next few years to a staggering 1,282 cases in 2019. Of course, during pandemic with social distancing, there was decrease in number of viral infections, and measles included. However, this emphasizes the importance of routine vaccinations and how drop in rates of routine vaccinations can allow breakthrough of vaccine preventable diseases. So vaccine hesitancy refers to delay in acceptance or refusal of vaccination despite availability of vaccination services. So when I use the term vaccine, I mean vaccination because it not only covers is not only related to just the vaccine per se, but to a wide range of factors such as immunization services, time and place of the immunization, fear of needles, etc. We all know that vaccine hesitancy has existed as long as there have been vaccines. And then in 2019, WHO declared that vaccine hesitancy was one of the top 10 threats to global health. Shortly after that, the COVID-19 pandemic emerged, and then that became kind of the world's predominant health concern. So when we think about vaccine hesitancy, there is this 3C model that has been proposed that takes into account the psychological antecedents to vaccination. So 3 of those to begin with we'll talk about are complacency, convenience, and confidence. As we talk about the vaccine hesitancy continuum, you know, acceptance of vaccination is kind of the norm in majority of populations, both in the US and globally. But then there is this continuum of people accepting vaccines, some of them accepting, some delaying, some refusing some, and then agreeable to others. And then at the far end of that spectrum, well displayed in this kind of pyramid shaped graph, is those who are vaccine refusers and vaccine deniers. And there is not much that can be done to shift the needle on that group, in my opinion. However, a lot can be done about the those who are in the the middle phase of that continuum. So when we talk about these 3 C's of vaccine hesitancy, beginning with vaccine confidence, we think of confidence as being trust in the effectiveness and safety of the vaccine. And also not just that, trust in the system that delivers the vaccine, including reliability and competence of providers who are providing the vaccine. And also, it also includes motivation, trust in the motivations of policymakers who decide which are the needed vaccines and which aren't. Complacency, on the other hand, exists where perceived risk of vaccine preventable diseases is low. And ironically, this is kind of the paradoxical result of our successful immunization program so far. People believing that vaccination is not deemed as a necessary preventable action because we don't see as many vaccine preventable diseases. Or maybe there are other life and other health responsibilities that take precedence. Complacency also exists where there is low self-efficacy. So that is the self-perceived or maybe the real ability of an individual to take an action to be vaccinated. And then there is convenience. How easily available is a vaccination to a person? The physical availability in places where people have to pay for vaccines, then are they affordable? Are they willing to pay for them? And then what is the accessibility, geographical accessibility to the vaccine? To the vaccination. Then also comes into play health literacy, and then the appeal of the immunization services. What kind of quality of services are being provided, both real and perceived, to the person to the parent or person getting vaccinated. And then the vaccine delivery has to happen in a convenient and comfortable manner, both related to time, place, and cultural context. After this 3C model, sometime down the line, were a couple additional C's that were proposed, and these include calculation and collective response. Calculation refers to the individual's engagement in information seeking for perceived risks of vaccination, perceived risks of disease. And it's been observed that individuals who are high in calculation should be rather risk averse. So, however, the more information a person looks for, the more vaccine critical sources will be obtained. So this is kind of supported by the false balance effect in the media. So even though across the board there are more experts who are pro-vaccination, what's presented in the media is an equal number of pro and contra-vaccination experts. So when people are seeking out this information, calculating their risks based on currently main source of information being the internet, they may be affected by this false balance effect. And the last in this model is collective response. What is the willingness of an individual to protect others by their own vaccination, in the sense kind of willing to be a part of the herd immunity? So there are values attached to these. There's collectivism, communal orientation, and empathy. And the converse to this is individualism, where a person is willing to free ride when enough of the others are getting vaccinated. Now, having low values of collective responsibility may indicate that the person does not know about herd immunity, or maybe does not care or does not want to vaccinate for the benefit of others. Shifting gears into kind of thinking about possible reasons for vaccine hesitancy. To the left of my screen, you'll see factors that contribute to vaccine hesitancy, and these have not kind of changed, or I should rather say they continue to their increasing factors that add on to this. So, of course, concerns over safety, prior experiences by a person or by their close contacts, close family, with regards to vaccination, or experiencing one of the rare adverse events with vaccination. And then their trust in health services, doctors, and a few of the other things that we discussed before, including being exposed to misinformation or disinformation. There may also be religious beliefs at play, or a preference towards a particular lifestyle of, following natural medicine. There is also the peer pressure that some of the families face from those who are vaccine hesitant or vaccine refusers. On the other hand, we have also seen during this pandemic some kind of reasons that were specific to the COVID-19, with the concern for how this new technology came into play at such a warp speed. And then again, the perceived lack of safety data, or in particular with respect to long-term safety. So I don't want to kind of read all of these, but I think we have all seen these evolve, these reasons for vaccine hesitancy throughout the pandemic. I've included some links to the CDC's myths and facts if you want to kind of look through. But the medical community has often focused on really correcting misinformation rather than actually understanding and trying to address underlying issues. May they be with regards to emotions, beliefs, and trust, that in the end up creating a fertile ground for many of these rumors that really take hold in the community and multiply. So let's kind of look in the first phase of the talk. I want to kind of go over the impact of COVID-19 vaccine hesitancy on the pandemic itself. So as we review the COVID-19 vaccination uptake, a total of 66% of the US population is fully vaccinated. And if you break that down to greater than 5 years of age, 70% of the population greater than 5 years of age is fully vaccinated. The CDC, I've included links almost in every website and that I quote. In the end, my references have links to the literature included. So moving forward, how has Missouri done with regards to vaccination? Here, I just wanted to kind of show that in Missouri, only 56% of the total population is fully vaccinated for COVID-19, and 60% of the population greater than 5 years of age fully vaccinated against COVID-19. So let's look at this heat map of COVID-19 vaccine hesitancy. This is data from a household pulse survey administered by the CDC. I mean, this is a whole year ago, but I think it's really helpful because I don't think the facts have changed very much in the year following. And of course, there will be more information coming up. But based on what this shows, during a collection, a survey collection period of couple weeks in 2021, they asked the question of once a vaccine to prevent COVID-19 is available to you, would you get a vaccine? And the options to answer were definitely get a vaccine, probably get a vaccine, unsure, probably not get a vaccine, and definitely not get a vaccine. So they used three definitions to capture the strength of hesitancy to receive a vaccine. And here in this heat map, I only included estimated hesitant, and you can look up the other data as well included in the links. But a hesitant includes survey response that would be probably not or definitely not. Further down in that tab is estimated hesitant or unsure, and there was also that added response of unsure. So when we look at survey responders who indicated they would probably not or definitely not receive COVID-19 vaccine when available, you can see that the lowermost tabs, that's 17 to 16.75 percent who were estimated to be hesitant, they kind of they seem to be accumulated in these specific counties indicated in yellow. And then I want to introduce this other concept of social vulnerability index, and which essentially means that it summarizes the SVI, summarizes the extent to which a community is socially vulnerable to disaster. So the factors considered in developing this index include both economic data and data regarding education, family characteristics, housing, language ability, ethnicity, and vehicle access. So a number, an SVI of 0.8 to 1.0 suggests a very highly vulnerable social area, and an SVI of 0 to 1.9 indicates very low social vulnerability. So if you interplay the prior map with this current map, you can see that the dark blues, which are the very high vulnerable areas, kind of in a sense overlap with those areas of vaccine hesitancy. And so this kind of helps to identify which are the areas in the state that need to, where additional targeted efforts need to be made to provide equitable vaccine access to COVID-19. Another very helpful map here that indicates, that kind of overlies the social vulnerability index to the percentage of total population who are fully vaccinated. So not vaccine hesitancy, but those who are fully vaccinated. And so in the far right bottom corner are those two kind of brown shades, which indicate both a highly vulnerable population that has low vaccination uptake. So my next slide, I just picked up these two from the heat map, and you can see where in Missouri, again, it's that same area where we saw vaccine hesitancy was the areas that overlapped with highly vulnerable population and low vaccination uptake. There is this other index called as COVID-19 Vaccine Coverage Index, and this is otherwise called as a CVAC index. It captures supply and demand related challenges that may hinder rapid and widespread vaccine access in US counties. So they kind of look at five specific themes, being historic undervaccination, socio-demographic barriers, constrained healthcare system, healthcare accessibility barriers, and irregular care-seeking behaviors. So here, a level of concern for a difficult rollout would be 0 would be lowest concern, and 1 would be the highest concern for difficulty in rolling out. So how did the rollout go in Missouri? So in the low CVAC index areas, the rollout was better at 72%, whereas in the high CVAC areas, the rollout was 57%. And this is for fully vaccinated persons in Missouri. Again, not all communities will face the same barriers. With regards to Missouri, the CVAC index kind of breaks down the barriers, and while an overall vaccine coverage index for Missouri is 0.74 with regards to barriers, you can see that historic undervaccination has kind of plays the biggest role. And so potential responses should be targeted against the barriers that are most likely, if addressed, to impact change in vaccination uptake rates. So for Missouri, that would be historic under-vaccination and healthcare accessibility barriers. While I've presented to you data on vaccine hesitancy, the coverage so far in our state and country, let's talk about how lack of vaccination or low vaccination uptake can impact COVID-19 hospitalization rates. So in this MMWR report back from January 2022, which was kind of the peak of the Omicron variant phase of the pandemic, when comparing those who received boosters or additional doses, so meaning fully vaccinated with the primary series and boosters, those who were unvaccinated were 12 times as likely to be hospitalized for COVID-19. And this would be unvaccinated adults. And along those same lines, adults who had only received the primary series without the booster or additional dose were 3 times as likely to be hospitalized than those who were up to date on their COVID-19 series. Here again is that a graphic depiction of hospitalization per 100,000 population. In blue, you have the unvaccinated line, and in the dashes below are those who received a completed vaccination series, which is the bottommost line, and then in the middle are those with primary vaccination series and no booster. And then we have all, during the pandemic, have seen how healthcare, how social determinants of health also impact the COVID-19 disease rates and COVID-19 hospitalization rates. By far affected are non-Hispanic Blacks, where during the Omicron peak, they were 4 times as likely to be admitted for COVID-19 hospitalization. And if you look at those who were hospitalized, 25% of all unvaccinated, the Blacks, hospitalized Blacks accounted for 25.2% of unvaccinated persons during the Delta predominant period, and a higher 31% of all unvaccinated persons hospitalized during the Omicron predominant period. Then what about vaccination status and COVID-19 hospitalization in children? This recent MMWR that looked at nearly 400 children in that age range of 5 to 11 years who were hospitalized during the first few months of the Omicron phase. So that would be kind of later part of December through February of 2022. 9 in 10 of these children were unvaccinated. 2 in 10 required ICU care. And again, coming to the point that it is not, even though we know that obesity, diabetes are big risk factors for COVID-19 hospitalizations overall, general tendency is to think that, yes, many of these COVID-19 would only affect those who have underlying conditions, who are immunocompromised. But it's striking to see that 3 in 10 of these COVID-19 hospitalizations had in children 5 to 11 had no underlying conditions. Again, there were disparities in the proportion of children affected by race and ethnicity. So the largest proportion were Black, contributing to 34% of these admissions, followed by white and Hispanic children. Now, multi-system inflammatory syndrome is a complication of COVID-19. There have been over 8,000 cases of MIS-C to date in children. And, many of these children have end up staying in the hospital for a few days, may end up needing ICU admission. But since COVID-19 vaccines became available for 12 to 18-year-olds, we have seen that the unvaccinated, again, are the ones who are disproportionately affected by MIS-C. So as such, from based on a case control study of 238 patients in 24 pediatric hospitals across 20 states, they were able to extrapolate in this MMWR study that the vaccine effectiveness against MIS-C was 91%. And again, it disproportionately affected Black and Hispanic children. Now, if you look at MIS-C rates by themselves, even in the pre-vaccine availability time, we knew that it was disproportionately affecting our Black children. And cumulative counts of over 8,000 cases of MIS-C, 57% of cases were in Black and Hispanic and Latino children. Again, none of the children who were vaccinated for COVID-19 but still developed MIS-C required life support as against those who were unvaccinated. I wanted to also share with you this paper that kind of takes into account internet search trends during the pandemic. So Google Trends accounts for 85. So Google Trends monitors the volume of searches conducted via Google. As a search engine, it accounts for like 85% of internet searches worldwide. So when the authors looked at the trends to investigate any possible association between COVID-19, the development of vaccine, and the anti-vaccination group terminology, there were some very interesting results. Through the pandemic, there were fluctuations in search popularity for phrases related to the vaccine. But it is very interesting that even with the type of vaccines that have been available, we still the search trends still go back to concerns about mercury, concerns about autism in relation to vaccine, kind of myths that have been dispelled a long time ago, but we know that still kind of permeate the vaccine hesitant thought process. So let's shift gears to saying, how did the COVID-19 pandemic itself affect routine childhood vaccination rates? As we think about the impact of the pandemic on vaccination rates, just kind of a reminder of when WHO declared COVID-19 as a pandemic for the first time. That was on March 11th, 2020. 3 days later, it was declared as a national emergency on March 13th in the US. And then on March 18, shortly afterwards, American Academy of Pediatrics advised pediatricians to restrict preventative care visits to younger children requiring immunizations. And at that time, that was, in the midst of an unknown kind of future for what we were going to see. That was kind of relevant advice. However, after that, we saw pediatric primary care volumes decline precipitously. And now there is a growing body of literature that is helping to define this impact and devise ways to address the impact of this lost care. From mid-March to mid-April 2020, doctors in the VFC, the Vaccines for Children program, ordered about 2.5 million fewer doses of routine non-influenza vaccines and 250,000 fewer doses of measles-containing vaccines compared to the same period in 2019. This was the MMWR publication that kind of shows in time point, this was throughout 2020, the decline in rates of ordering of these vaccines. In comparison, here is the data depicted in a figure format showing that dramatic drop in change in doses of non-influenza vaccines ordered under VFC. And then moving on, we also saw that subsequently during that June to September 2020, there was again a decline in vaccinations, routine vaccinations, even though preventative care visits were meant to be catching on by then. So in this MMWR study of 10 US jurisdictions, the in comparison from June to September, in comparison to the same period from 2018 and 2019, DTaP vaccination declined by a median of 9.1% in less than 2-year-olds and 6.7% in the 2 to 6-year-olds. Similar declines were seen in MMR vaccination, HPV vaccination, and Tdap vaccination. And then, even though administered doses increased during June to September, this increase was not sufficient to achieve catch-up coverage. So in these two figures, on the left, you see MMR doses. On the y-axis, it goes from March 2020, start of the pandemic, to September. As you can see, on the y-axis, there is the percent change. So there was kind of catch up, or an attempt to catch up after in that June to September period. However, we did not achieve sufficient catch-up coverage for that time frame. And a similar kind of statistic for HPV doses administered to adolescents 13 to 17 years of age. When we look at this report on vaccination for kindergartners in 2020 and 2021, the vaccination coverage nationally, so this included state and local immunization programs across US states, including DC, the coverage was about 93.9% for 2 doses of MMR, similarly close to 94% for DTaP, and the same for state-required varicella vaccine. Compared to the same period from 2019 to 2020 school year, the coverage decreased by approximately 1% for all vaccines. So MMR coverage and exemptions for more than one vaccine decreased in approximately 75% of US states. Now, across the country, 2.2% had vaccine exemptions, and 0.2 only being medical, 1.9 being non-medical. However, despite only 2.2 having vaccine exemptions, additional 3.9% of children who could have received the MMR vaccine did not receive it. So students, again, not fully vaccinated and not exempt, increased in majority of states. And this ranged from state-wise. Those who are, again, out of compliance with school requirements also varied across the states. For the 2020, in this figure, you can see kind of a depiction across the states of MMR coverage as a percent point change in comparison to the prior year. And you can also see rates of exemption, and those who did not have an exemption but were provided a grace period for, or were provisionally enrolled in anticipation that they would get the vaccine. So for 2020-21 school year, coverage was approximately 94%, as I mentioned before. The exemption rates again remained low. In this figure, you can see that even though among the 33 states with MMR coverage that was less than 95%, so the goal would be to achieve a MMR coverage of 95%. All but 2 could achieve this goal of greater than 95% if those who were non-exempt, or those who were within that grace period, provisionally enrolled, or out of compliance, if they were captured, then all of these states would be well above the 95% goal. A surveillance study that used a pre-pandemic, post-pandemic control design with data from 8 healthcare systems in the states that are listed here showed that weekly vaccination ratios during that age-limited preventative care period was 0.82 for less than 2 year olds, and as low as 0.1 for 16 to 18-year-olds. And then following that time when preventative care was limited to less than 2 year olds, when primary care was expanded later on after months into the pandemic, it was still the 16 to 18 year olds had a weekly vaccination rate ratio of only 0.57. So depicted in this graph, you can see the trends. The dark blue line is 2019 data, and then the orange is 2020. And then the graphs are shaded with the blue indicating the time before the pandemic, the pale color that indicates age-limited preventive care, and then starting kind of late May onwards, primary care was expanded. So you can see how in the 16 to 18-year-olds that rate ratio of vaccination is kind of still is low. And then when you look at a proportion of individuals, so children who are up to date for routine vaccinations, just looking at the infants who are 7 months old, in September 2020, only 74% of infants were fully up to date on their vaccination. So in this graph, again, dark blue line indicates 2019, the orange line indicates 2020. So you see how compared to 2019, when 81% of 7-month-olds were fully up to date on vaccines, only 74% in September 2020 were up to date on vaccines, and similar comparatively lower proportions for 18-month-olds as well. With regards to proportion of individuals up to date for vaccines by race, you can see here by race and ethnicity. The color coding is blue being Asian, orange being non-Hispanic Black, light blue being Hispanic, and gray being non-Hispanic white. So as such, it is concerning and striking to see these disparities where, while in May 2019, even in the pre-pandemic period, only 70% of Black infants at 7 months of age were up to date on their vaccines, in comparison to 82% when you use across all race and ethnicity. And then in September 2020, things got even more bleak, where only 61% of Black infants were up to date on vaccine, in comparison to 74% of combined across all categories. So I hope I've kind of made a case till now for the impact of COVID-19 vaccination on the pandemic, and how the pandemic itself impacted decreased childhood vaccination rates due to accessibility, due to social distancing, etc. So this last part of the talk is more conceptual than with as much literature base supporting it, because this literature is coming on. We will see this pan out in the next year or so, where I expect to have more information and studies on the impact of the spillover, as you may say, of COVID-19 vaccination into vaccine hesitancy to routine vaccination, and that indirectly having an impact on decreased childhood vaccination rates. There are a number of news articles, pieces out there with a number of providers in the community actually seeing this unfold in front of them. So in this survey of looking into parental perspectives on routine vaccinations, comparing them before and during the pandemic, the survey was conducted by a team at Children's Hospital LA. Among 252 participants, the survey found that overall there was increase in childhood vaccine hesitancy, increase in risk perception related to vaccines, and no change in vaccine confidence during the pandemic. And this it kind of reassuring to know that, based at least on the survey, that this increased hesitancy did not translate into a decreased intent to vaccinate with routine vaccines or influenza vaccine. So per the survey, during the pandemic, one of the main reasons for vaccine hesitancy was due to routine vaccines was due to increased risk perception. And some of the key demographic factors included household income and race. So during the pandemic, households with higher income correlated with decreased routine childhood vaccine hesitancy. And again, Hispanic ethnicity and Black race had an increased risk perception during the pandemic. It's helpful to know that that the COVID-19 vaccine hesitancy can also have its impact on caregivers' willingness to vaccinate against influenza. In this survey of caregivers, that was actually an international survey, but included 5 US emergency departments at the peak of the COVID pandemic. Now, granted, this was earlier on in the pandemic. 54% of caregivers plan to vaccinate their children against influenza the following year. So this was an increase of 15% from the prior year. And 28% of those who did not vaccinate in the previous year plan to do that next year. So here I'm kind of sharing with you how early in the pandemic people were willing to have influenza vaccines at a higher rate than they did in the prior year. And some of the factors that predicted this willingness included children's up-to-date vaccination, wanting their child to be up-to-date, the caregiver's history of influenza vaccine, and the level of concern they had for their child getting COVID-19. But did that really pan out in this season? So that was a survey from early 2020. And now we have vaccination coverage information for influenza from 2021-2022 season. What actually panned out was the opposite. Even though, at least based on that small survey, people were willing to vaccinate against influenza, what really happened was vaccination coverage rates decreased by a few percentage points for all children in the range of 6 months to 17 years. So in comparison to April, the week of April 9th, ending April 9, 2022, comparing that with the same time in 2021, there was a 2% point drop in flu vaccination coverage. And if you compare that with a pre-pandemic time period of 2019 to 2020, so that's kind of 2 seasons ago, there was a 6.9% drop. There was also difference by race in vaccination coverage, where Black children had 8.1% lower vaccination coverage for influenza this season compared to white. So that was 47% compared to 55%. And now even amongst white children, there was a drop in percentage points compared to the prior season. I want to share with you this National Strategic Plan for United States, where the vision seen by the HHS is for United States to be a place where vaccine preventable diseases are eliminated through safe and effective vaccination over the lifespan. Also including here some of the information from the Immunization Action Coalition on exemptions that are available to school and childcare facilities across the country based on 2019, where in Missouri there are medical, religious, and personal belief exemptions. And there are only few states in the country which have medical-only exemptions as of 2019. The National Strategic Plan aims to increase vaccinations with a target of achieving at least 95% of children enrolled in kindergarten to get both doses of MMR. And similarly, at least 85% target for DTaP, at least 4 doses by the second birthday. And to keep the vaccine, non-medical exemptions for vaccine at a low percentage of less than or equal to 2, and increasing the percentage of young adolescents receiving HPV vaccine by to above 80%. So, what can we do then to restore parental confidence in vaccination during the pandemic? Now, we know what happened was there were restrictions in routine in-person office visits due to physical distancing protocols during the pandemic. And this kind of limited actual face-to-face contact time of healthcare providers in promoting vaccine uptake. So one of the means would be to kind of to increase confidence would be to have these discussions and use strong presumptive languaging so that there can be a consistent and effective recommendation, and emphasizing on prevention of disease and prevention of cancers when it comes to HPV vaccine. So in 2019, it's very helpful to know that based on this one study, they showed that HPV coverage among adolescents was 74% when providers actually recommended it, as against only 46% in those who did not have a provider recommendation to get the HPV vaccine. And then kind of thinking about what works to increase vaccination uptake. So this is kind of a similar kind of 5C model, but kind of focuses on the same concepts, but putting it down more simply. So, where work needs to be done so that the end product is that the child receives recommended vaccines. So there should be impacts on changing the way people think and feel. So increasing their confidence in the safety and benefits of vaccine, increasing confidence in the providers. And then there's also kind of social processes. So recommending vaccinations by the provider, the family supports for vaccination, increasing family supports for vaccination. And then this would lead to the motivation to get vaccines, and then making sure that access to vaccine is affordable and easy. This paper kind of is a really good read, and I would encourage you to kind of look through how each of these boxes is addressed in there. Also discussed here in this paper are what are the areas that are most likely to have an impact on increasing vaccination uptake. So interventions that target direct behavioral change are the most promising. And research supports that the use of many different techniques is helpful. So there is no single intervention that's effective on its own. It kind of emphasizes the importance on adopting more than one strategy. Now, interventions to change what people think. So that top box there, the top few there, are often expensive and hard to sustain, and they may not be effective as much. Of course, an important caveat is that intervention by a healthcare professional on the way people think in a clinical setting will be influential if they use effective communication strategies that are based on information and engaged listening. Now, I think it's important that middle area there, which is interventions that target social processes, they have kind of more lately have had an outsized influence both from coming from public sphere and from private settings. And they've had an increasing influence on programs and policies. So how do we bridge this gap that has been created by the pandemic, just by way of the disease itself, the interventions that were put in place to control the pandemic, and by vaccine hesitancy from COVID, related to COVID-19, that kind of has seems to have shadowed the pre-existing vaccine hesitancy for children. So what can we do? So some of the things that can be implemented could be leveraging sick visits to catch up vaccination in children who were missed during their preventative care visits. And then using provider level techniques and training and empowering providers to use kind of a presumptive approach to recommending vaccines, or using motivational interviewing, kind of seeking out what the parental concerns for regarding vaccines are, and providing kind of strong and persistent recommendations. Another strategy to kind of implement would be use of reminder call systems in a variety of ways: mailings, telephone calls, text messages, and in those who are able to have access to the healthcare portals, sending portal-based reminders. And also identifying kind of for healthcare systems to identify vendors who can help them implement these kind of reminder call systems. Utilizing school-based vaccinations, we know there historically that these have been effective in the US, especially during outbreak settings. And there is strong evidence that shows that having mandates supports and maintains high immunization coverage in the K-12 schools, colleges, universities, and healthcare systems. Again, thinking of how insurers can incentivize primary care practices in order to be able to increase vaccination rates. Policy changes need to happen to expand vaccination requirements. And contrary to at least current beliefs, majority of the population, including parents, support various forms of compulsory vaccination. As a trusted source of healthcare, providers, pediatricians, family docs can both advocate and support for vaccine mandates, focusing on basically the underlying evidence of effectiveness on vaccines rather than getting into political and ideological considerations. So this is another good read by Miller that I have included a reference below. So in summary, I hope I have made a case for showing how both the COVID-19 pandemic itself and vaccine hesitancy related to COVID-19 has impacted decrease in rates of childhood vaccination, also by route of increasing vaccine hesitancy to routine vaccination. I've included all my resources here. As I mentioned before, there are links to the literature that is cited in my talk, and I'm happy to take questions. I also look forward to hearing from conference attendees what your experiences have been, and if you would like to kind of share your thoughts and additional kind of thoughts regarding how we can bridge this gap that has been created during the pandemic. Thank you.